Welcome to Fertility Fact or Fiction. I'm your host, Dr. Rahi Victory. You can hopefully see us and hear us on TikTok and as well on all the other platforms. If you're just joining us, Dr. T, as he likes to call himself, is not with us tonight. He's remote, but he is available and online, so you'll still get to hear him. Happy fast breaking to you, buddy. You probably can break your fast right about now, right?
Right about now. Right
Excellent.
about now. Yeah.
Yeah, that's good. So my apologies for being absent. I was sick one week and then I was on call another week and had to do 3 surgeries when we had the show. So we are rearranging my call schedule so I'm not away anymore. And then the other time that this happened was a religious holiday for me, which was just this most recent Tuesday that passed. So sorry, folks, we definitely wanted to be there for you. And I apologize for being absent. It won't happen again unless it conflicts with a religious holiday. So thank you all for waiting. We figured this week, since we were away for so long, we would just go straight to questions for you. I don't see any of the questions on my page. Do you?
I see them. Yeah, I see them. You don't see any of them?
No, nothing's showing up for me. I don't know if I
Oh,
need to like
no, no,
refresh.
no one typed in. No one typed one in yet. That's all. On the side there. That's all.
So nothing on the restream side.
That's right. Nothing yet.
Okay. All right. Well, yeah, we're open to taking your questions. Nothing super exciting in the fertility world. There was the whole thing, obviously, with Alabama. It seems to have settled down already. There was definitely mass panic from everybody wanting to move their embryos, but thank God that's all settled quite a bit. There are some posts from some of my colleagues about Ozempic babies where women have gone on Ozempic and then lost a bunch of weight and then they're suddenly getting pregnant. That's obvious. We've known for ages that if you lose weight, it improves your chances of success. And so there's no question that being on those GLP-1 inhibitors will improve your chances of getting pregnant because you're losing weight. So that's a no-brainer. The problem, you're not actually supposed to get pregnant while you're taking those because we don't know what the long-term side effects are on pregnancy. So if you are taking one of those to lose weight, fabulous, but maybe don't do it while you're trying to get pregnant because that's probably not a great idea. And I see some pictures coming through.
Oh yeah.
I mean, not pictures, some questions coming through. So T, you can fire off
Yeah.
whenever you like, buddy.
I'll bring up some from Instagram because they've been patiently waiting already.
Okay.
Can you carry your baby if you have complete DQ alpha match gene, or is surrogacy the only option?
Yeah, so the DQ alpha gene is very controversial. I tried to find every study I could on it, and there were like a couple that said it was the worst thing ever, and then another one said it didn't matter, and then another one said it was DQ Bravo and it had nothing to do with DQ alpha. And I've never seen anybody test for DQ Bravo. So I don't know that it's been fully worked out. There is likely a huge number of patients who are full matches and have absolutely no problem. Realistically, we're only finding out about the patients that have it when they're already dealing with a problem. And then we have to go looking for it and figure out, is it a problem? Is this the source of the problem? So do we have patients with full matches that get pregnant and have their babies successfully? Yes. Depending on who you talk to, some people will say subcutaneous IG or IVIG. Dr. Zaneku, my buddy, has previously recommended using heparin. And as well, you can use possibly lit therapy, which is what Fertility recommends. So there's different approaches to it. At the end of the day, I don't think we have enough people or enough science on it to know for sure what the right approach is. But there is no question there are probably millions of people out there who are full matches who are getting pregnant and having babies. We don't even know about it. So I don't want anyone to think that just because they're a full match, they're never going to have a child. Likelihood is very high you would. You may need some treatment, but the likelihood would be very high that you'd be successful one way or another.
Hello, Dr. V. I did laparoscopy surgery 2 months ago, and now I have a big cyst on my right ovary. What
Well,
are the treatments?
Well, I would want to know what kind of cyst it was. Like, is it an inflammatory cyst where things have kind of walled themselves off? In which case, you need to have that looked at, because that doesn't necessarily need anything. Or is it a cyst in the actual ovary? And then if it's in the actual ovary, you need to know what kind of cyst it is. Most cysts will resolve on their own, and so nothing is needed. But depending on what kind of cyst it is, sometimes you'll need repeat surgery. So you'd have to see the physician that did the surgery and then figure out what's going on.
Hey, Dr. V, and the T. Can you discuss what is happening with SCIG?
Yeah. Um, so an overzealous physician in northern, well, not even northern, more like eastern Ontario, decided that they didn't like the fact that sub-QIG was being used for fertility. And so they complained, and then they complained to the company and said, this is not appropriate. And so the company stopped using it. And so they won't give us access anymore unless the government decides. So Dr. Zaneku and I are in the process of asking the company to, essentially give us, not the company, asking the government to give us, the ability to do it, but we haven't done that yet.
From YouTube, is the chance of a miscarriage reduced with an FET with a genetic tested embryo?
Yes, it's drastically reduced in that situation.
Dr. Victory, tips on getting through all the medication side effects. Started menopause yesterday and I am so nauseous, and letrozole and trigger gave me horrible migraines.
Well, if you're getting horrible migraines from letrozole and Lupron, or triggers and stuff, you need to talk to your physician and change your meds. Migraines are not always that safe, so I would take that with a bit of caution, and maybe stop. So that's something where you got to talk to your physician. Stop.
Hello, handsome and genius doc. That's all for you, believe it or not. There's nothing there for me. And then it's a Haley Sweet. If downregulation wasn't an option, would IVIG alone increase your implantation chances for endo patients? What IVF protocol for good embryo quality?
If downregulation wasn't an option, would IVIG be
Yeah.
sufficient?
Mm.
No, not at all. There's no evidence that I'm aware of that IVIG is beneficial for patients with endo. There's probably evidence out there, but I've never looked that up, to even know if it's out there or not. So IVIG, the whole reason you're downregulating is to suppress the endo and thereby suppress all of the immune changes that go with it. You're not going to get that with IVIG. So no, I would not think that that's the same.
From TikTok, what supplements or vitamins to support thin lining? Also on estrus, gonoleptin, progesterone.
C, D, and E are all helpful. Aspirin, it's not really a supplement, but it's readily accessible, so that's an option for you too. And then as far as supplements, there isn't really a whole lot more that's going to help with your lining. Medications, there are that can help. L-arginine is one supplement that people talk about that might be useful. L-carnitine as well, but there isn't a lot of supplements that help with lining thickness.
Another one from Instagram. Hi, Dr. V. What do you suggest for priming in those about to undergo IVF with stage 4 endo and low AMH? What about alternating HGH during stims versus priming 2 weeks before?
Say that again.
Yeah, there's a lot going on there. Okay,
Yeah.
I'll break it down for you.
Yeah.
What do you suggest for priming with those about to undergo IVF with stage 4 endo and low AMH?
Oh,
That's
so let me
the
take
part.
that part first. Hang on.
Yeah,
So Testosterone and human growth hormone, no birth control. That's easy. And DHEA, if you want it as well, those would all be reasonable primers. And then what was the second half?
And then the second half was what about alternating HGH during stims versus priming 2 weeks before?
I don't know what you mean by alternating, but we started essentially 2 weeks before the stim and then just keep it on until you're done your stim. And that seems to give us the best result. It's interesting, like, I think there's some misinformation out there on HGH. I spoke with a patient from the States yesterday who was put on HGH multiple times. And part of the issue she was having with their cycles was that the follicles were actually developing too quickly. So, like, HGH accelerates that. So why would you put someone on HGH when they're already getting accelerated follicular development? So it didn't make sense to me. So HGH only does one thing. It makes you make more follicles. It may improve blastocyst quality. It may improve fertilization. We're not 100% sure. We know it does increase the number of eggs you make, and it'll increase the maturity of the eggs that you make. But they've actually not been able to prove definitively that it increases live birth. So whether or not it's actually valuable, we're still working out. We're not sure. I do use it because I think those other benefits are beneficial, but whether or not it's actually making a long-term ultimate kind of goal difference, we don't know for sure. It's not 100%.
Hello, Dr. Victory and Tarek! Exclamation mark. Is 28 nanograms per liter of progesterone and 50 nanograms per liter of estrogen the day before transfer okay? Thanks, pretzel emoji from Munich.
Yeah, those are good numbers.
Those are good numbers.
No problem with those. From Munich?
Yeah.
Wow, that's late night in Munich. Sorry for keeping you up. Yeah, it's like 2. Well, they're 6 hours ahead. That's like, yeah, 2 in the morning for them. Ouch.
People stay up all night.
I know they do. It's true.
It's a great
Yeah,
show.
it's true.
I don't even want to miss this show, and I'm not even trying to get pregnant.
You know what was funny was I was in New Zealand and Australia last week, and there were people there that knew who we were because of the show. They had watched it. And then I listened to the stories of the care that they're getting. And for all those of you that are unhappy with your fertility care in Canada or the US, it is horrifically bad there in Down Under. It was terrible. Like, the things they were telling me were crazy. One guy was getting an egg donor, anonymous egg donor, who was 37 years old, and he had to pay for all that. Like, it's crazy how bad the fertility care is there. So they won't listen to anything. They won't agree to doing anything different. They just keep saying, no, no immune, no steroids, no intralipids, no anything. Just keep coming back and doing more IVF till it works. It's insane. And I thought it was way cheaper down there. It actually isn't. So we had a lot of people that actually want to come and see us here now from Australia and New Zealand. And then people were begging us to go there and start a program there. So, yeah.
Hi, Dr. V and Awesome T. Does the cytoestrogen and fenugreek cause problems for fertility? If you have endo, I read that it doesn't, but I don't know if that's true.
No one's ever demonstrated that phytoestrogens have any impact on your fertility. So I'm not worried about that at all. If you want to have your tofu, have your tofu. It's not a big deal.
Fenugreek is tofu?
No, but there's phytoestrogens in tofu.
Oh,
If you want to have fenugreek, have fenugreek. The phytoestrogens are not going to be a problem. You'd have to eat a truckload of it to be an issue anyways. And phytoestrogens do not activate endo in the same way that synthetic or natural estrogens do.
That's kind of what I was thinking as well, to be honest. Do women ovulate in every cycle? Thank you.
No. No, there's lots of women that don't ovulate all the time. So, and you can get what is like a period without actually ovulating. So yeah, not everyone ovulates all the time.
Does the MTHFR genotype 677TT, two variants, have anything to do with recurrent early pregnancy losses?
Yes. And I'm getting private feedback that says they can't hear you well. So
Oh,
you
so they
may
want
need,
to hear me.
yeah, yeah,
All right, I'll increase my volume.
yeah, increase your volume or whatever. Yeah, MTHFR mutation can have a very significant negative impact on miscarriage. So those patients, we use methylfolinic acid, and we use the like 5-methylfolinic acid instead of folic acid, and we use aspirin and heparin.
You'll like this one. Hey, Dr. V and Mr. T. Fertility doctor and my family doctor refuse to treat me for ureaplasma. Advice.
Find new doctors. I mean, that's silly. There's no way you can justify not treating ureaplasma. It's a known infection. It's a pathogen. It doesn't belong there. It's not part of the natural flora. It has a significant association with um, the miscarriage risk in animal studies. Now, granted, and I've said this many times before, there is not good data to support the idea that ureaplasma is directly associated with miscarriages in humans, but we suspect, how, based on how strong the animal data is, that it's true in human beings as well. Either way, it's a pathogen. It does not belong in the vagina or the uterus. And so eradicating it just makes natural sense, even if you weren't trying to get pregnant. It doesn't belong there. It shouldn't be there. So they should be eradicating it. If you've got a fertility specialist that refuses to treat it, you need a new fertility specialist. The little troublemaker that told us that the volume was not good happens to be my daughter, and she now gave us a thumbs up to suggest that
Wonderful.
it's much better. So, yes,
It was intentionally softer just to not overpower, the actual content because
there
sometimes you
you
talk and I talk at the same time. So I wanted to give hue to the real host of the show.
go. No, no, no. You're actually probably the host of the show. I'm like the sidekick, man. I just
Oh
answer.
yeah, yeah, yeah. You're Robin now, are you? That's funny.
That's it. My
Yeah,
name starts with an R.
yeah, that's right. Okay. How often, this is on TikTok here, how often are you on call in the hospital? I will hold her in until you're on call.
I'm on this Sunday. Usually I'm on like once a week, maybe once every 10 days. There's 11 of us in the city, and we break up call. So I mean, technically we're on like once every 3 days. Every 10 or 11 days. Sorry, yeah.
When would it be appropriate to ask for a referral to your clinic? 36, been trying 5 months, has one loss.
Um, Now, because by the time you get to see me, it'll be another couple of months, and so that's an appropriate time to ask for a referral. Technically, over the age of 35, we tell you 6 months of trying, but by the time you actually get in to see us, it'll be more than 6 months. So that makes sense for you. And if you get in and you get pregnant, just cancel the appointment. No big deal.
Dr. V, this is
Yep.
clearly just for you, this question here. So, and it's a big question. It's split up into multiple parts. So get
Oh,
ready for this.
oh boy. Okay. Should I take
Yeah.
notes? I'm ready.
I'm not sure.
I'm
There's
ready.
no
Go.
big numbers here. It's just goes on for a little bit.
It's okay. I'm ready. Go for it.
Okay. I'm 35 years old, G2T1, with a 9-month-old baby and 6 untested frozen embryos left.
Okay.
Mixed feelings on trying naturally when we have embryos created at 32 years old.
Okay.
Thoughts on younger embryos versus natural conception. Also, still breastfeeding and would love to not have to stop, but also anxious to get pregnant again. What are your thoughts on FET while breastfeeding? Thank you for all you do. I'm certain your treatments of my chronic endometritis using Fertility is the reason we have our baby boy. Big heart emoji.
Super cute. Well, thank you. So, yeah, I mean, I would highly recommend that you finish your breastfeeding. We never recommend that people try and get pregnant while they're breastfeeding. It does make it much more difficult. So, we never would agree to an FET while you're breastfeeding. You need to be done. On the flip side, you're young, you're only 35, you've got a lot of embryos. You made them when you were really young at 32. So I would actually say finish your breastfeeding, try natural. If it doesn't work within 4 to 6 months, then we can start using your embryos again. So I would be very comfortable with that approach to things. What you should not do is try doing an embryo transfer while you're breastfeeding because that won't work. If you get pregnant naturally, that's fine. You still probably need to stop breastfeeding, but at least you did it on your own. It cost you nothing. Hopefully, it was fun, and away you go. But if you're doing IVF where you got to pay for all this stuff, don't do that while you're breastfeeding. That is not going to work.
Is the chance of a miscarriage reduced with a genetic testing embryo in FET?
You asked that. I
Okay,
said,
great.
yeah, it's drastically reduced.
Hi, Dr. V and Mr. T. Oh, we did the rear plasma. Oh, people are jumping around. It's not that I asked it twice. It's just they have different profile pictures on
That's so
different platforms, and it throws me off.
platforms. I know they if they don't get an answer right away, they jump to the other
Yeah,
platform.
absolutely, absolutely. And then
Yeah.
I get a lot of fan mail about my asking skills, my question asking skills. So I'm just trying to be fair to everybody.
We
You
need
know,
AI to read all the questions and then just limit it
Ver-
to us, not giving us duplicates.
that's it. I had an IVF treatment and got pregnant. However, it was a chemical pregnancy. I am 45 years old and was told by many IVF centers that I am too old. Would you accept me as your client?
Yes, absolutely. We don't have any age that we don't accept unless you're into your 60s. Once you're up past 55, there's ethical concerns with the fact that your chances of not be excuse me, of not being there when the child is in their teens or 20s is significant enough that that becomes an ethical dilemma for us. So 60s is a problem, but 45, sure, I'll take you. Can I promise you you'll be successful with your own eggs? No. Are we going to have a discussion about donor eggs? Yes. Will I try for you if you want to and you know what your risks and your benefits are? Sure, absolutely, we will.
I have a fantastic question for you.
Okay,
That,
there was one right below that one that you didn't ask me though, but go ahead. I'm all ears.
yeah, you're going to like this one. So we have a viewer on TikTok, and they're
Okay,
asking,
yeah.
"Hi, doctor. Why is it that the doctor I'm going to requested I do an ERA before my IVF?"
You love getting me going. So the ERA test has been proven to be useless in multiple articles. So if you have a doctor that wants you to do an ERA, you need to ask that doctor to provide you with evidence to support the fact that the ERA works, and then take them the randomized controlled trial that was from Doyle and Kevin Richter, Richter, reviewed that study in a different way and demonstrated from the Doyle study, which was published in the Journal of the American Medical Association, that ERA can't even detect if you're actually receptive or not. It's incapable of doing what the company actually designed it to do. So, based on that, anyone that supports the ERA is either not aware of the fact that it doesn't work, or hasn't read the fact that it doesn't work, or whatever, or maybe they feel that it works, even though there's clear proof that it doesn't, but it doesn't. Like it's incontrovertible that it doesn't.
I also feel it doesn't work from my experience, to be quite honest.
Yeah, because you've been around me ranting about it for 4 years now.
So I have a question that's based on one of the answers that you gave.
Okay.
Sorry, doc, what did you use to treat the endometriosis?
We use Lupron and Letrozole. We use supplements, NAC, curcumin, resveratrol, ALA, and coenzyme Q10. There are some other ones you can use as well, but those are the mainstays for us. And then we use high dose progesterone, double, both vaginal and injectable. And then we do a very good embryo transfer if it's IVF. And then we have an immune protocol, intralipid steroids and tacrolimus. So that's what we use.
From YouTube. I'm approximately 5.5 weeks pregnant from an FET with practically zero symptoms, just a bit more tired. Should I be worried?
No, I mean, symptoms, people ask this all the time or get nervous because they were feeling queasy and then suddenly they don't feel queasy and they're like, oh my God, am I losing the pregnancy? And I get it. I respect the tremendous sense of fear and anxiety that comes along with any fertility pregnancy. So I'm not discounting that. Having said that, the symptoms of pregnancy have absolutely zero bearing on whether or not you're pregnant or not. So every woman will experience different symptoms, and the same woman can experience very different symptoms in different pregnancies. So I have patients where they had absolutely no issues in one pregnancy, and then in the next one, they had lots of issues with nausea and vomiting and feeling tired and all sorts of things. So, I mean, anytime you're worried, see your doctor, get a beta HCG or an ultrasound, depending on where you are in the pregnancy. But, sitting there worrying about it is just going to make you ill and make you miserable. So don't do that. Seek out the help of your physician, ask for another test, and get the reassurance you need.
Yeah, when my wife was pregnant, I was going through a lot of stress myself. So, you have to everybody's got to breathe a little bit as well.
Yeah, buddy, you're heavily outnumbered by women here. So before you get flamed on social media for highlighting you in the midst of that, I would maybe backpedal that one just a little bit.
You know,
Yeah, on behalf of Tarek, he apologizes.
yeah.
I'm just gonna put it out there right
Trying to bring the spirit of the show alive. You know what I
there.
mean?
You
Because
go. Yeah.
because we've been remote for so long, that face to face is necessary. So
Were we remote the last one we did, or were we together? Oh, we were
we,
remote.
we were remote. We've been remote for a while.
Oh my God, we haven't been together forever, man. That
Yeah,
sucks.
yeah.
Are
That's what
you
I'm trying
back
to say.
next week?
No, next week I'm also out of country. It's a really strange week. It's a really strange
Dylan,
week. Yeah.
they're gonna miss you.
That's why I have to make some of these jokes that are, potentially not the best jokes.
Where are you going next week? You didn't tell me.
Oh, next week I'm going to Istanbul.
Oh, back to Istanbul.
Back to
Cool.
Istanbul. Yeah, yeah,
All
yeah.
right.
Back to
All right.
Istanbul.
Cool. Good.
Okay. I'm just saying hi. Thank you for all your help with your lit therapy. We are getting there.
Oh, awesome. Well, hello back, and you're welcome. I love
Uh,
lit therapy. We do like 2 of those a day now. It's crazy.
Lit therapy is
That's
amazing.
three.
I'm a big fan of lit therapy, to be
I
honest.
love it. Yeah. Yeah. And by and large, we're getting most of our patients to have positive antibodies. So that's really good. It's not for everybody. So I'm going to work out the donor lit thing soon.
Mhm.
Oh, someone just said they came back from Istanbul.
Oh,
Welcome back.
Istanbul's great.
Yeah. Cool.
Gold Sky should tell us how much they liked it because I think
Yeah.
it's top notch.
Yeah. I barely
Um,
got to see Australia or New Zealand. I literally was in Auckland for a day, and then I was in Brisbane for a day. I saw about 200 feet down the street from the hotel. That was as far as I
that was
got.
it, eh? That's a
Yeah.
shame.
They did make a good cappuccino across the street, but that was about it.
My biggest struggle traveling overseas is actually coffee. That's one of my biggest things because I'm a big fan of putting cream in my coffee. And when you go to like Europe, they don't do cream, they just do milk or
Yeah.
cappuccinos with frost milk. And,
Yeah.
I've become used to the Tim Hortons cream, that 18% pure fat in your cup. And, nothing
Yeah.
hits home like that.
That's Wendy too. Yeah, see, I drink my coffee black like it should be.
There we
So
go.
yeah.
Hi, Dr. V. I'm 42. I see LH surge every month in the ovulation kit and a dominant follicle on ultrasound. We are trying the last 3 months not to result yet. Is there a possibility I am not ovulating?
Not if you're seeing a positive surge and you have symptoms and you get premenstrual syndrome and all that stuff. No, you're probably ovulating.
Um, Hi, doctor. How can I get contact number to your clinic?
From our website or email info@drvictory.com. But our clinic contact number is all over our website, www.drvictory.com. Or just look up Victory Reproductive Care online. T, maybe you can like put one of your banner thingies up there and people can see it.
Yeah, I'll do that for sure.
Uh,
Hi, doctors T and V. Oh wow,
Oh, you like that one.
this is a good one. This is a great patient. I'm a big fan of this individual. If a patient has a consultation with you in June, how long of a wait for IVF if ready to proceed right away? Well, I'll be honest, me myself personally, I'm technically available.
For that doctor, yeah.
For that doctor,
He,
yeah.
he is ready right away. Um, if you're truly ready, we can basically go ahead almost immediately. Like we need the time to check everything. My nurses are going to get angry with me, so I'm going to be careful with what I say. We need the time to validate and verify that all of your tests are up to date. Infectious disease screening, your vitamins, your hormones, your thyroid, all the stuff that we need to make sure you're going to do well. So, given the opportunity to make sure we have everything we need for you and that you've selected a package and you've paid for your IVF package, and then that you know how to use your meds and you know your protocol, we're ready to go. So, I mean, in a rush, like for a cancer patient, we're like 24 hours, we get our patients running. So, can it be done quickly? It can be done very quickly. For everybody else, I mean, obviously, we're not getting people running up in 24 hours, but if there's a reason to hurry, we can. I just need to know why. And then we never want to rush fertility treatment. We want to do it well. And so I tell everybody, in fact, I was just in San Francisco at a meeting telling this to someone who really wanted to hurry. And I said, listen, rushing fertility only makes me rich and makes you poor. So don't do that. Make sure you're getting it done the right way.
Absolutely. Um, IVF and ICSI male factor, none of the 11 mature eggs fertilize, sperm donor a likely option, and IUI.
I would need to know more about how bad the sperm was and what techniques they used to improve it, and then your partner's habits and so on. I mean, IUI would be an option with donor sperm, sure, but I need to know everything about you, and then I need to know everything about your partner. Can't answer that one without a lot more information.
For a modified natural transfer, is 6 days or 5 days ideal post ovulation?
Post ovulation, it should be 5 days.
Okay. Last frozen embryo, waiting for laparoscopy for endodiagnosis. UK wait is 1 year. Would
Ugh.
you suggest down regulation before trying a natural FET, immune and progesterone with trigger protocol in place?
Yeah, I mean, we would recommend our protocols. So 3 months of Lupron and Letrozole. Take the anti-endo supplements I mentioned, excuse me, earlier, and then make sure that you're getting high dose double progesterone, and then go into it with an immune protocol. Is really tough to get an immune protocol in the UK, but the rest of it you can get. So yeah, that's what we would recommend.
How long are progesterone suppositories beneficial in early preg due to spotting and previous loss?
How long are progesterone suppositories necessary?
Beneficial in the early pregnancy. That's what the question says.
We continue it till 12 weeks.
Is being dehydrated helpful for embryo transfer?
Is being dehydrated helpful? How can being dehydrated be helpful? No,
I don't know. I'm just
definitely
reading
never
them.
be dehydrated. hydration is critical for a million different things. Um, so yeah, always be hydrated.
I'm a big fan of hydration. Hydration is good.
Yeah, Tarek and I both need to stay very hydrated
Yeah,
because we get kidney stones. So
yeah. We're
definitely,
sensitive.
yeah.
Um, 33 years old, G3PO, one ectopic and two losses, history of PCOS, and left salpingectomy.
Okay,
Other tube normal confirmed by HSG.
okay.
Do you think IVF is the best choice?
No, no. You have lots of options. You could try naturally. You could try with insemination. You could try with IVF. I would want to know why you had an ectopic. Was there signs of infection? Was the tube damaged? Was there endo? I mean, there's more to it than just the superficial approach, but you have options. I wouldn't rush into it.
My HCG went from 2,250, 14 DPT
I saw.
to, you
Yeah.
saw that one? Okay.
Yeah.
To,
So, yeah, she has a 71% rise. No, you
yeah.
don't need to worry. It's fine.
Okay.
Yeah.
I am an old patient. Do I still have to get a referral?
You need a referral if it's been more than a year. So, yes, please. If it's been more than a year. If it hasn't been more than a year, it doesn't matter.
Dr. VNT, my prolactin is high, but macroprolactin is within normal range. My naturopath suggested Vitex or Chase Tree. Thoughts?
I'm not aware of any studies supporting Vitex or Chase Tree for bringing down monomeric prolactin. We treat it as a medical problem because it is. So, in those circumstances, we actually give you medication like bromocriptine or Dostanex. I think we missed one earlier, a couple earlier. Do you want me to read ones I'm looking at?
Okay, go ahead.
Let me see. There was, where was it? Oh, what does a true natural FET cycle look like at VRC? Did you see that one?
I see it. I do
Yeah.
see it.
So true natural cycle, we don't do a lot of, but basically we would wait for you to surge, and then 7 days later you get, excuse me, your embryo transfer. I still have a cough from my pneumonia not too long ago. So yeah, we would go ahead and watch for your LH surge, and then 7 days later you get your transfer. So 2 days after your surge, you start your proj, or you can start it with the surge and then do your transfer 5 days later. Got to watch your progesterone levels really carefully because we're giving you high levels, and then as your body starts producing, you got to drop the levels that we're giving you. When is progesterone started? I just answered that. Is there flexibility in the timing of a natural FET? No, there's zero flexibility. There's just that 2 days depending on when you start your proj. And then the next one above that was High T and Dr. V. Does it matter when stim for IVF starts? I know it usually starts on 2 or 3. Would starting on day 5 affect the cycle? Yes. Your dominant follicle will be ahead of the other ones, and it may be hard to get them to line up. So we usually start day 2 or 3 for that reason.
All right. Instagram. Hi T and Dr. V. What do you recommend if you need to lose 40 pounds before transfer, but you are 41, so time is not on your side? Asking for a friend. It's me. I'm the friend.
Yeah, that's funny. Yeah, so 6 meals a day: breakfast snack, lunch snack, dinner snack. Low calories, like 1,500 a day. Um, Daily exercise where you're building muscle. So that's not walking. That's not a treadmill. It's not yoga or hot yoga. It's like muscle building, like you're in the gym trying to bodybuild. And then if you're 41 and you're trying to lose 40 pounds quickly, I would actually talk to your doctor about a GLP-1. If it's that much weight, you need to talk to your doc about getting on something that will help you lose the weight.
IVF and ICSI, none of my None of the 11 mature eggs fertilized.
We did
What are
that.
the options? We did that. Okay.
Yeah.
How long will it take for you both to ask the government? I'm supposed to start SCIG in June.
Oh,
I was
it's
told,
yeah, it's government. I mean, God, it'll be forever before that becomes realistic. They're not going to take a look at that and say they're just going to rubber stamp a $10,000 per person treatment. So anyone who needs sub QIG, you either need to buy IVIG, which is absurdly expensive, or you need to go with intralipids and steroids and the alternatives. We don't have a fix for this, guys. It's going to be a long time, and they will very likely reject, the attempt to get it covered. Very likely.
can you talk to me about using a known donor? What's the process? I'm doing IVF with you in a few months. How long will it take to complete all the necessary steps if I only just identified my KD?
We just need to screen them and test them, and then they have to be known, meaning you have to be willing to be exposed to whatever they have. Despite that, they still need extensive testing, as do you, and then we're ready to go. But
I
you
did
have to be comfortable with the risk associated with being exposed to that person. So, for example, you're a female, your known donor is for sperm, you have a good friend, he's whatever, heterosexual guy, he's not in a committed relationship, he goes out to the bar, he has sex with someone, that person has whatever, HIV or hepatitis C or something bad like that, he gets it, you're now exposed, and it's very possible that it's within a time frame where we can't tell you that he was positive, because if he gets it and we didn't know that he got it, um, because it won't show up in testing for months sometimes, you could be exposed to something bad. So you're technically supposed to be having sex with the people that are your donors, technically, but you ultimately just have to be willing to accept the risk. You have to know the person, like, if it was your partner's brother or something like that and you knew them well enough, then that's fine, but not just some dude you met or lady you met.
There you go. Dating advice from Dr. Victory.
Yeah.
Yeah.
Fertility dating. Yeah.
Fertility dating. Absolutely.
Yeah.
Uh, Dr. V,
Yeah.
I'm 35 years old. G2T1 with nine tests. What is a 9 month old? Oh, we did this. Sorry, sorry.
Yeah.
There's just so many windows here. Okay. You know what? Let's just go back to Instagram. I did matrix testing and it found a low immune response. What would you suggest?
Sorry, say that one again.
I did the matrice testing
Oh,
and
yeah. Matrix testing. Yep.
yeah, and it found I have a low immune response. What would you suggest?
I need to know what the results were. It's not something I can answer like that.
Hi, Dr. VNT. Can you please compare the benefits of Orilissa versus Lupron and whether letrozole should be used with either? Are natural FET cycles possible after either?
Um, okay. So there's no evidence that Orilissa is beneficial prior to a frozen embryo transfer. Um, so I can't compare. I can only tell you that Lupron with letrozole is beneficial. Lupron alone is not. It is likely that Orilissa and letrozole would be beneficial, but likely there's no evidence. So I don't actually know for a fact. So um, people that try that, they're doing it with no scientific evidence to support doing it. It makes sense. It has theoretical advantages, but we don't actually know if it works or not. With regards to a natural FET after a Lupron letrozole downregulation, you'd have to wait a month, but the following month after, yes, you could do a natural.
I had to take progesterone during my entire pregnancy, vaginal suppositories, and then was upgraded to shots. Is it likely that I may need to do that again with my next pregnancy?
Well, I would just start with the shots and the vaginal together. So hopefully you wouldn't need to do that.
Hi, Dr.
Yeah.
Victory. I have endometriosis and mild adenomyosis. I did some immune testing and found high TNF-A for Th1 and Th2 cytokines ratio and low LADs. Would you advise Humira and Tacro for the cytokines?
Yes.
How can a 20-year-old
Yeah,
woman?
I like the easy ones. Yeah.
I expected a lot more because it took me way more effort to read that than yes.
Yeah. No, that one was easy. Yes. Use Humira and use Dacro.
Yeah.
Yeah.
How can a 20-year-old woman diagnosed with PCOS uh, who never got pregnant get pregnant?
Well, I would need to see you and assess everything, but PCOS doesn't stop people from getting pregnant, it just makes it harder. So as long as you're ovulating and you're healthy and your weight's reasonable and the sperm quality is good and you don't have bad habits and your vitamins are good and your supplements are okay and all that stuff, you should be able to get pregnant. We have loads of patients with PCOS where I tell them not to do IVF because they don't need to do IVF. They'll get success with just trying on their own natural with just some help. So if you're young and you're healthy, as long as your weight's not a big issue, you should be able to do it without very much difficulty. Even if weight is an issue, as long as you can work on the weight and get it to come down, you'll be fine.
I have endo and mild adeno. After 4 months of Lupron and letrozole, I had a chemical. My progesterone 2 days after transfer was 186 uh, nanomoles per liter. Is that normal?
It's a little high. We're aiming for like a top line of 150. So I don't think it would stop you from getting pregnant, but it is a little bit elevated.
Is menopausal taking 0.05 milligrams of levothyroxine? Are there any risks of taking L-theanine?
L-theanine?
Yeah.
Not that I know of, but I'd have to look that one up. We don't use L-theanine very often.
Would you recommend using progesterone suppositories after ovulation?
Yes, I am a big
True.
progesterone. Can I just point out this question from Case? Did you
Yeah.
see that?
Go ahead.
Help doctor, will I be okay if I take 3 Adderall and 5 Mollies? Like, where do these people come from? I think the fact that you're asking that question is probably a pretty strong indicator that you are not okay. So maybe you need to rethink that one. Also, probably not the right show for you. Go ahead.
Hi, Fabulous T and Dr. V. Should let be used during stims if suspected OHSS?
Yes, because it'll keep your estrogen levels lower, which reduces your chances of having OHSS.
Should your partner also be treated if your immune testing comes back positive for things like endometritis, ureaplasma, mycoplasma, etc.?
Always. We treat both.
If my wife's blood came back with high rheumatoid factor, how is that normally treated or can it be?
Steroids is what we would use, aspirin, steroids. Rheumatoid, I like to use heparin as well because it's a good anti-inflammatory and there's some blood clotting association. But the mainstays would be aspirin and I mean steroids. That would be the main actor in that situation.
Is the normal method to treat an unknown fertility issue with letrozole, overdrol, and progesterone? Seem to be doing the same thing cycle after cycle for IUI.
No, it's actually funny. So a patient that I spoke to today was working with a very famous U.S. clinic, very famous, and said that she was diagnosed with unexplained infertility, and they gave her letrozole and timed intercourse with an ovidral trigger. So that's been proven not to be beneficial. So I was like, why is the like #1 U.S. fertility clinic and one of the bigger fertility clinics worldwide suggesting to do something that's useless? I have no idea. Ovidrel trigger with letrozole is useless for unexplained infertility. It has a 3.7% success rate, and your success rate naturally trying is between 3.1 and 4.3. So you are at no benefit from taking letrozole. It is absolutely useless to you. Don't do
I'm telling you, so that question there, I could have, if that patient saw me, Dr. T could have wrote up a better script.
that.
I could have done it. I'm telling you.
I think it's actually getting to you, man. You're gonna. I'm gonna enroll you in some med school courses or something
I'm
like that.
telling you, it's a passion I never knew I had.
We
That's just.
we're gonna send you to one of those island schools, and you gotta go become a doctor. It would be cool. I mean, it would take forever, but it would be cool if you came back and we worked together.
Oh yeah, that'd be all right.
That
That'd be
would
all
be.
right. So many people say that MTHFR genes do not impact miscarriages. I have it and had 7 until I went on blood thinner and aspirin for my successful pregnancy.
Yeah. So many people say so many things about so many different things. And I think the reality is, there's no reason to listen to everyone. The thing that you need to do is do the research for yourself. And, as a physician, I'm not saying you guys need to do it, but I need to do the research, understand the science, look at the articles, figure it out. So we get doctors all the time that say, immune treatments don't work, lit doesn't work. Like, there's a meta-analysis on lit. It shows a 45% increase in live birth. I don't know how much more than that you need to consider that proof. So for all the doctors who are saying there's no proof, you're not reading. It's not that there's no proof, you're just not reading, plain and simple. So I mean, it's hard for me to sit there and listen to people say that this doesn't work and that doesn't work, or they shouldn't treat this or shouldn't treat that, because there's clear evidence for some of this stuff. Some of the stuff there isn't, and I'm honest about that, and I tell people. But for the stuff where it's clear, like MTHFR, you'd be crazy not to be on aspirin and heparin.
What is the decision making between a 35-hour trigger versus a 36-hour trigger for egg retrieval?
Well, you probably will have fewer people pre-ovulate when you're doing a 35 versus a 36. However, when we did 37, because there was a study that said you'll get more genetically normal embryos, we had a lot of people releasing their eggs, a lot. And so we went back to doing 36. So we're at the 36 now, because in our hands, we had too many people releasing prematurely.
I'm 33 and my AMH level is 8.4 picomoles. Does it consider very low?
Yes, it's low. I don't know that I'd say it's very low, but it is abnormal for your age.
Would you suggest genetic testing at the age of 28?
You mean PGT testing? No, I can't say that I would. I don't think anybody's advocating for that unless you have major issues or recurrent miscarriage, or you don't want to keep a million embryos. Then sure, there are reasons to do it, but generally speaking, no.
Hi, Dr. VNT. What is more ideal, 5 or 6 days after ovulation for a modified natural transfer?
5.
5. How does high prolactin affect fertility?
It suppresses estrogen levels, and therefore the lining of your uterus becomes unfavorable for implantation. So that's how it impacts fertility.
2 euploid embryos, 4
Okay.
AB and 3 BC, no
Okay.
fertilizis, transfer upcoming, thinking use 3 BC first. Thoughts?
What was the other one?
4 AB.
Well, your 4AB is your better embryo. Why would you use the 3BC first? I don't understand the logic there. Somebody let me know.
Jay is asking, where's your necklace?
Oh, you know what, honey? I left it at home today, but I faithfully worn it every day. My daughter bought me this beautiful David Yurman Leo necklace with this lion on it. It's awesome. I'm sorry, sweetheart. I did not wear it today. I should have remembered in the morning, but my back was hurting so much I couldn't think about anything but the pain. But I
I
love
have
it.
high.
I do wear it faithfully every day.
There you go. That's nice. I have hydrosalpinx in both tubes. Should I have the tubes removed before
Yep,
IVF?
absolutely. It's a 50% reduction in success. You should definitely have them removed.
37, one pregnancy, T2, endo, TTC, 5 years. What can I expect treatment wise?
Oh, I have to see you and figure it all out. I mean, that's not something I can answer without knowing all your details, but you can expect testing, and then you can expect us to talk to you about some type of endo approach, whether it's surgery or IUI or IVF, and then we would go through the details of what each of those would look like. So if you do surgery, you might be able to try natural. If you're doing IUI, you might want to wait for the surgery. If you're doing IVF, we have a sequence we like to follow, which is make your embryos, get suppressed, do your surgery while you're suppressed, and then do your embryo transfer.
I've had multiple miscarriages and just started a new doc after listening to you.
Yeah,
Did MRI and endo, thought I was told it wasn't a problem with previous doc, started letrozole, changed diet, and acupuncture.
cool, good. That all sounds perfect. Any doctor that says endo is not an issue is not reading.
That's a very polite thing you just said. I was going to say something more extreme, but I think maybe I
Yeah,
should just keep it to
I'm
myself.
trying to be politically correct more these days. I don't want to. I don't want to piss anyone off. So I'm trying to toe the line and be a fair player.
Absolutely. Dr. VNT, I had Bartholin gland cyst marsipultization.
Martialization, yeah,
Yeah, but it recurred. I
yep,
had negative full infectious screening. I
yep,
haven't had salpingography yet. Is
yeah.
there a possibility my tubes are blocked?
Your Bartholin's and your fallopian tube have absolutely nothing to do with one another. Zero. They're like not related in any way. So Bartholin's is a gland at like the 3 and 9 o'clock position, just about an inch into the vagina, and the duct that is connected to the gland gets blocked from cells and debris and whatever's in there. And then when it gets blocked, the bacteria grow and it gets really swollen and horribly painful. Marsupialization is where we basically take it and split it open, and then you sew the edges to the vaginal wall so that it has to stay open and hopefully just gets essentially spat out. So it doesn't always work, and depending on how good the marsupialization is, and whether or not they pack it and things like that, it doesn't always work. So in those cases where it doesn't work, you need to address that appropriately and redo it. So we'll redo it like 2 or 3 times. If that doesn't work, you actually have to remove the Bartholin's gland, which is not a fun procedure. It's difficult and it can leave some scarring, and the patients aren't always comfortable with sex. So it's not an easy procedure.
As of my understanding, I need a referral as a new patient to your clinic, and the waiting period is 6 months. While waiting to be seen by your clinic, which vitamins do I take and what is the ideal weight?
So the waiting time is not 6 months. I don't know where someone found that out from, but no, it's not 6 months. We are seeing people sooner than that, and we will have another doctor joining us soon, so it'll be even sooner than that. And vitamins. So your prenatal vitamin, fish oils, melatonin, coenzyme Q10, vitamin D, and iron.
Where are you located in Canada, Dr. Victory?
Windsor, Ontario, Sarnia, Ontario, and St. Catharines, Ontario, and soon Woodstock, Ontario. So St. Catharines is about to open. Woodstock is, we're still trying to get a quote on construction, but it'll be ready once that part is done.
Hello, Dr. V. I was diagnosed with chronic endometriosis. I'm 38 years old, divorced due to not being able to conceive a baby. What treatment do you recommend?
Well, I need to see you, and I'm so sorry that you got divorced over not being able to conceive, but I need to see you and figure out how bad the endo is. There's different treatments for that, so it depends on what it is.
Hi, Dr. V. Is an anti-ROSSA positive results a fertility or pregnant concern?
It's definitely a pregnancy concern because it's very highly associated with miscarriage and possible fetal heart block. But it's possibly a fertility concern if you have other things that go with it and like that increase your risks of clotting, as well as the fact that if your estrogen levels go high from, let's say, IVF, and you have a clotting risk, now you have a super clotting risk. And so those are patients will often anticoagulate during their stim. So yeah, there can be issues with that.
9 o'clock.
Okay. I think we need to call quits. Have you eaten?
No, of course not.
Oh my God, you poor thing. Okay, we're gonna let T go because he needs to go break his fast. I'm sorry, buddy. And you all have a wonderful evening. We will be back next week. When are you going to Turkey?
Next week. You have the. I think I go on the 1st or the 2nd.
Okay. My wife's abandoning me on the weekend, so if you want to do
Oh,
a
we
weekend
should.
show,
We could do something on the weekend for sure. I have no objection to that.
all right, let's do a weekend show.
Okay. For our
Okay,
overseas people, have a nice time in the afternoon or something for them.
we'll figure it out. I don't know if I'm busy all day, but yeah, we'll do.
Okay.
No
Yeah,
worries.
yeah. All right.
Have
We'll
a
do
good
that
one.
for sure.
All right.
Okay.
Thank you, everybody. Love you all. Stay safe and lots of prayers. And if anyone knows good therapy for my horribly uncomfortable back, let me know. Happy Ramadan, Dr. T from Gold Sky. Have a safe
Oh,
trip.
that's
There
nice.
you go.
Thank
Can I please repeat the vitamins? Sure. Prenatal vitamin, coenzyme Q10, fish oils like omega-3 fish oils, vitamin D, iron, and melatonin. All right, guys. Have a good night.